Well, good afternoon, everybody. Thank you so much for staying with us till the bitter end. I'm impressed. My name is Dr. Melissa Rahill. I'm from the University of Buffalo, SUNY, and I'd like to also particularly welcome our virtual audience, so thanks for tuning in to us today. A reminder to please silence mobile phones. You can access the program materials online or through the AAN Conferences mobile app. Remember, an evaluation must be completed for this program to receive your CME credits. All evaluations must be completed by May 1st, so you have a little bit of time, but don't forget, those are available online or through the app. The AAN strictly prohibits all unauthorized photography, audio, and/or video recording of any kind in programs. Later on, we're going to have a Q&A session at the end, and so to submit questions for Q&A, you can either scan the QR code, which I hope will be on a screen later, or you can type in aan.cnf.io and select this course. This program is supported in part by an educational grant from Lundbeck. The Academy was solely responsible with no influence from the industry supporters for selection of content, format, presenters, and moderators of this CME program, and the speakers have not been contacted or influenced in any way by the industry supporters with regard to this CME program. And I will say, we just learned about the fact that it was sponsored by Lundbeck about 5 minutes ago, so I can wholeheartedly attest to the validity of that statement. Okay, so, without further ado, let me introduce our amazing team today. So we're going to be kind of doing a case-based review of some updates in the migraine world, and we're going to be bantering among the three of us. And I'm very thrilled to announce our first presenter here is Dr. Rebecca Birch. Dr. Birch is the director of Headache Medicine, the Headache Medicine Fellowship Program and an assistant professor of neurology at the University of Vermont, Larner School of Medicine. And Dr. Dina Kurovila is neurology and headache medicine medical director at the Westport Headache Institute in Westport, Connecticut. And they're my dear friends, and I'm so happy I get to do this with them today. Okay, so disclosures. I personally have no relevant financial disclosures for today's talk. You can see Dr. Birch's disclosures here and Dr. Kurovila's disclosures here. Okay, so what are we going to talk about today? Here are some goals and objectives. We hope to discuss pearls to taking a good headache history. I know it seems kind of simple, but after doing this for a long time, there are some nuances that I think are worth mentioning. We will review the approach to using acute and preventive migraine therapies. We will highlight new acute and preventive therapies, which I'm sure you're all curious about, especially you non-headache specialist folks out there. And we will be explaining the importance of shared decision-making when initiating treatment. Okay, so let's start with our first case. So Erica tells you she has some bad headaches. She's a 38-year-old high school teacher with severe headache. She recalls headaches in college that would sometimes cause her to miss class, especially prior to her period. Recently, her pain is worse, and she's getting one severe attack per week, and her over-the-counter medications just aren't helping like they usually do. She describes pain as being across the front of her head, and it starts sort of dull and builds to a throbbing headache. And she notices that she's nauseated when the headache is particularly severe. So what's the diagnosis, guys? While you're thinking about that, to my esteemed colleagues here, what are some of your pearls for eliciting an accurate headache history? What do you guys think?
You know, first and foremost, I think I try to think about red flags and green flags in my clinic. Red flags being any warning signs or anything that comes up that makes me want to further work up the headache and obtain imaging, lab work, other consultations from other clinicians. You know, the most common secondary headache disorder is post-traumatic headache, and so I try to elicit the history really to identify those red flags, such as that head trauma history, history of cancer, a change in the duration of the headache, the frequency of the headache, new onset, sudden onset headache. So I try to look really for those red flags first, and then I also look for green flags, those comfort signs that make me feel better that the diagnosis is truly migraine. And some of those comfort signs are someone who has a history of headache remotely during childhood, or a past history of headache or migraine. Another one is if there's a menstrual association with the headache that they're coming in with. There's a number of those different green flags that we try to identify too that make us feel better in general. So that's kind of how I approach it first.
How about you, Dr. Birch?
Yeah, I look for all of those same red flags and green flags, but I wanted to take a step back and also talk about how I kind of approach interacting with the patient, which is that when they sit down, one of the things that I often say first is tell me your story. Start at the beginning and tell me the story of your headaches and what brings you in. And I'm listening carefully for the words that the patient uses because that helps me get a sense of the quality of the headache and how it's affecting their life, and also sets up an opportunity to establish rapport and really help patients feel heard. One other pearl that I think is important in a situation like this, when someone has pain that starts less severe and maybe gets more severe, sometimes their headaches probably won't get as severe. And so it's important to make sure that we're asking for details of the most severe headache type as well as the least severe, because often migraine can present on a spectrum. So one of the pearls that I always tell our residents and fellows is that if someone is having headaches severe enough to be in your office, you should assume that it is migraine until you convince yourself otherwise.
Absolutely, great points. And I love the point about telling the story, because oftentimes people, are waiting months to see you, right? And they know that from past experience, they only have so much time to communicate their concerns to their physician because, modern healthcare. But I think it's super important to start from the beginning. And so they want to tell you about the things that have been happening recently, but you really have to start from the beginning. Okay, so let's talk about migraine. First of all, migraine is not a hysterical woman's problem. It is a real disabling neurological disease. It's not just a headache. There are sensory, autonomic, vestibular, cognitive, and GI symptoms that are associated. It's sort of a whole body phenomenon. And it's common. It's so common. That's why we as headache specialists have great job security, unfortunately. I'm always trying to, we never have a shortage of patients with headache, unfortunately, but we're working on it. There's over 47 million Americans with migraine, and 10% of school-age children have migraine. And so about 3 to 5% of Americans have chronic migraine, and I believe the current world burden is around 2%. So it's incredibly common. I mean, raise your hand if you yourself have migraine. I do. Okay, so I don't have to convince anybody here. And then again, migraine is disabling. So it's the leading cause of years lived with disability in people under the age of 50 worldwide. And as you know, it really strikes people in the prime of their lives, people who are trying to, have a family, people who are trying to get ahead in the workplace, people who are trying to be productive members of society. So this is a huge societal burden. So how do we make the diagnosis of migraine? I'm sure all of you in this room feel confident in making the diagnosis, but hopefully we can share with you some pearls. So listed here is the International Classification of Headache Disorders, diagnostic criteria. And so you have to have at least 5 attacks lasting for at least a few hours in your life to meet criteria. You have to have 2 out of the 4 of the following features. At its worst, it's usually unilateral. It can absolutely be bilateral, but usually at its worst, it tends to pick a side, but it's not side locked. Usually it's pulsating or throbbing in quality. It's usually moderate or severe in intensity, okay? And that's in contrast to tension type headache, which is really a mild to moderate headache disorder. And then lastly, aggravation by or causing avoidance of routine physical activity. What this means to me is when you have a headache, when it's at its worst, you just don't feel like going to the gym. You just don't feel like going to the grocery store after work. So a lot of people say, well, I push through when I have a headache, right? But that's not what I'm asking. I'm asking, what is your body telling you to do? What are you compelled to do? And then you have to have at least one of the following: nausea and or vomiting, or photophobia and phonophobia. So I don't know why this is, but I feel like everybody always denies photo and phonophobia. Again, we're not asking if it, we're asking, what is your body telling you to do? What are you compelled to do? So some people will say, well, when I go into a dark room, it doesn't help. That's not what we're getting at. And sometimes you have to be kind of creative in how you ask these things. So I have 2 young kids, so I never like to hear my kids screaming. But if my headache is hurting, then it's even more intolerable. No offense, kids, I love you. But it's even more intolerable with headache. Okay, so you have to kind of get creative. To make the diagnosis of chronic migraine, you have to have, at least some kind of headache, usually tension type or migraine, at least half the time for at least a 3-month period. And at least 8 days out of the month should be migrainous in quality. So they should fulfill the criteria for migraine or be believed by the patient to be migraine at onset and relieved by a triptan or ergot. So what other pearls do you guys have in making this diagnosis?
Well, again, I think recognizing that patients can have a range of headache severity, that there are less severe and more severe attacks, and sometimes we need to ask explicitly about that. I also think that inferring from behavior is a really important point. So, again, you ask, are you sensitive to light? Does it bother you? But I do actually think the question, do you prefer to be in a dark or quiet room when you have an attack, is extremely useful, because people will often say, yes, I prefer, not to have the TV on, and that's a clue that you can make a diagnosis with phonophobia as one of the criteria. And one other point is just that if you are looking at the slide there, you need either nausea or vomiting or both photophobia and phonophobia, so that's something that sometimes trips people up.
I think that we can't talk about diagnosis unless we talk about misdiagnosis. Because most of these people come in and they've carried these diagnoses of sinus headache, temporomandibular dysfunction, sinus issues, allergies, cervicogenic headache. I mean, these are the most common misdiagnoses we see, and many folks may have carried one of these diagnoses for over 20 years. And so when they come into your office, they've already bought into that diagnosis, and they have a hard time believing that they have migraine. So that's a really difficult thing to break if somebody has, for example, thought they've had allergies and sinus issues for 30 years, they've had multiple surgeries for that, but they actually had migraine. I think the biggest thing is making sure to make sure that we're not providing a misdiagnosis, and then take that next step to diagnose them accurately and initiate the appropriate treatment early in the course, because there are other specialties, that I've seen in my clinic that are going to diagnose them with sinus headache and sinus issues, and our dental colleagues may be diagnosing them with temporomandibular dysfunction or teeth issues. So we have to really be on top of that.
Great point. Yeah, I try to be inclusive about capturing their headache. So I say, my definition of headache is any discomfort above the neck. So regardless of what you think it's from, be it from sinuses or whatever. So I try to be inclusive about that. Okay. So this kind of segues into this idea. Am I making myself clear? There are a lot of misconceptions and miscommunications that are easy to make in eliciting this headache history. So, your patient might say that they get 4 migrainous headaches in a month. And so I might interpret that as, they have 4 migraine days per month, but the patient actually is feeling a migrainous headache for 2 days in a row when they get an attack. So really, they're talking about 8 days a month, okay? So it's important to clarify that. Some patients will tell you that they have cluster migraines, which of course is not a diagnosis in the ICHD, but there's some diagnostic confusion because oftentimes headaches sort of cluster together, quote unquote, in time, and migraine certainly can do this, and it's absolutely distinct from a diagnosis of cluster headache. And some patients will only sort of count their days with migraine aura and headache as a migraine day, when in fact many other days out of the month might meet criteria for migraine without aura. So it's important to capture those days. Okay. So again, how many migraine attacks do you have in a month? 4. How long does the episode last for? 2 days. Any other type of headache? No. And then you have to ask, I think the most important question when you're trying to get a sense of how frequent someone has symptoms is how often are you completely crystal clear? How often are you completely headache free? No discomfort above the neck. And that will, the inverse of that will give you their headache frequency. So in this particular case, they really feel like they're crystal clear the other days, thankfully. And so 8 days of headache per month, this person probably has episodic migraine. So I included this slide just to make a point in that your diagnosis really does matter. Because if you miss the diagnosis of chronic migraine, you are probably not going to capture the degree of disability that this person has. As you can see here, the more monthly headache days per month, the higher the degree of severe disability associated with their headache. And so making that diagnosis, capturing the true frequency of headache and other interictal symptoms really does matter. I like to ask, and I'm sure these amazing physicians do too, how does migraine affect your life? So you can read some of these patient testimonials here, but one person says, at work, I've had to call out a couple of times. One day I almost threw up in the classroom. I mean, can you imagine as a teacher? I try to hide it and just power through, but my family knows. My kids can see it on my face. Mom has a migraine again, and she feels that they're disappointed. So I think it's really important to put that out there and just put things into perspective. Remember, it's not just a headache, right? So there are different phases of migraine to consider. A lot of time, people have symptoms even in between attacks, sensitivity to light and sound, nausea, fatigue, etc. They're worried about when the next attack is going to come. That counts. And then some people have a prodrome where they start to get, food cravings or irritability, etc. And then, of course, some people, about 30%, have aura. And then there's the acute phase of the headache. A lot of people have a postdrome, or what we in the business call a migraine hangover, where it just takes a while to kind of get back to your baseline. And then, of course, back to the interictal symptoms. So it's not just the headache that is the concern. So this sort of just basically shows my last point in that you really have to be mindful of the interictal burden, because that helps to lead discussions about your treatment. Okay, so explaining the diagnosis. I mean, I'm a self-proclaimed nerd here, so I actually pull up these nerdy pictures in clinic with my new patients, and I find it to be really therapeutic to be able to kind of explain to patients the why. They come to you with all these different symptoms that might seemingly be unrelated sometimes, and when you can really tie it all in together and explain it in a neurobiological way, I think it actually helps to empower the patients. So I make it a point to talk about the trigeminal cervical complex. So hopefully you all remember from medical school that the pain and temperature pathways of the trigeminal nerve go down basically into the high cervical spinal cord, the spinal trigeminal nucleus, right? And so there's this convergence of the high cervical afferents back here and the trigeminal pain and temperature afferents over here, okay? So we call that the trigeminal cervical complex. So it kind of can help explain a lot of the time when people have chronic migraine, they have a lot of neck pain and tension. They're buying $100 pillows every month. It sort of makes sense to me why this whole system is on fire if things are not well treated. The other thing I actually show them on this picture is the connection between the hypothalamus and the trigeminal cervical complex. The hypothalamus, I think, is so interesting in its relationship to migraine. So it's no surprise that when you have a change in your sleep pattern, if you're about to get your period, if you're stressed, if you skip lunch, how all these things might modulate the activity of the trigeminal cervical complex. and sort of a light bulb goes off in your patient and they say, oh, that's why that happens. So what's your favorite way of explaining the diagnosis, guys?
Well, first off, I think I'm going to schedule an appointment with you. It's a lot of great education here. So the first thing is I first start with expectations and set expectations with the patient that there is no cure for migraine. Because a lot of people think that we're going to provide 100% resolution of the disease, which is just not true. And then I let them know that managing the disease is really the key. Just like you manage your diabetes, hypertension, and other medical conditions, we really have to focus on managing the disease. And I don't go into this diagram specifically, but I do try to draw out specific areas of the circuit for the patient just to explain why they may have neck pain or pain within the forehead or those different areas.
I think in addition to explaining that there is no cure for migraine, I also think it's important to tell patients that we're not missing some underlying cause for their headache. Many of my patients will say, okay, but I want to know why. I want to get to the bottom of this. I think, we're missing something because I'm having headaches and I'm not supposed to have headaches. So I actually take a very different approach, which is to give a neuronal overview. So I tell my patients that the brains of people with migraine are fundamentally different from the brains of people who don't have migraine. And we know this from functional imaging studies and lots of other research as well, that the brains of people with migraine process input differently than the brains of people who don't have migraine. They're more sensitive to input and they don't integrate input in the same way or as well as people who don't have migraine. And I also talk about the fact that the brains of people with migraine are not as good at resting and resetting. We know that the default mode network does not work as well in people with migraine. So I kind of go from that end of things. And that, I think, helps them understand that that is the cause, that their brain is not the same as the brains of other people.
Well said. I love it. Okay, so as we've already kind of talked about, there are some common diagnostic pitfalls. So sinus headache might be actually facial pressure, and you can have autonomic features with migraine, so it's no wonder why some people sort of assume that perhaps it's sinus related. People can have legitimate cervicogenic headache, like they can have high cervical facet arthropathy and high cervical radiculopathy that might contribute to a migrainous headache. But a lot of the times we're really just looking at peripheral and central sensitization that occurs from poorly controlled chronic migraine. And then tension type headache, again, remember, this is a headache disorder that is mild to moderate in intensity. And I don't see a lot of tension type headache in my practice. I know I'm biased because I'm a headache doctor, but I don't see it a lot. So people aren't coming to the doctor a lot of the time because of tension type headache. And then one last point on this case. So I want you to challenge the utility of tracking triggers. So for me, I feel like triggers are sort of a marker of someone's underlying disease burden. And if you initiate good treatment, or if you have a natural improvement in someone's headache pattern with time, usually your sensitivity to triggers kind of fades as well, hopefully. And then if you're saying, well, as long as I avoid, chocolate and hot dogs and direct sunlight and my children, I feel great. But then you have to think about quality of life, right? And so these things are not ultimately causal. So I don't really practice a lot of trigger avoidance, but I do respect it if someone says, every single time this happens, I get a headache. It's important to listen to that. Okay. Let's go to case number 2.
All right, so I'm going to be talking about acute treatment. So we're going to start with this case. So this is Sheila. She's 24 years old, and she has episodes of unilateral moderate to severe attacks of pulsating head pain with associated light sensitivity. She has nausea and vomiting if pain is more intense. What's the diagnosis? We just talked about it. She has pulsating, unilateral, moderate to severe head pain. If you want to make it 4 for 4, I'll tell you that she likes to lie down with her headaches. She also has nausea, which by itself is enough to make the diagnosis, but she also has phonophobia and photophobia. What does she have? Migraine. She has migraine. Okay. Her symptoms, worse with movement. So ibuprofen used to get rid of symptoms within an hour, but it's been less effective for her over time. This is a common time when people present to our office when the over-the-counters stop working for them and they need more intense therapy. She has 2 or 3 attacks a month, often associated with poor sleep or stress, very commonly reported things that are associated with migraine attacks. She's never been given prescription medication in the past. So I want to hear from my colleagues what treatment gaps exist for her and what would you prescribe as a first-line treatment? Dr. Rahill, let's hear from you first.
Do you want to advance back to the case?
Sorry,
Yeah, that's okay.
Okay.
All right, so I don't really like to be all that pushy about medication, but the one thing I'm pushy about is if someone's vomiting, you can't function. So I really try to make sure that I'm offering an antiemetic therapy. So if this person's vomiting, I definitely want to address that. I probably prescribe some ondansetron, although it's not going to help the pain of headache. You definitely want to preserve their functioning.
I think the most important thing, at least for the patients I see in my clinic as a headache specialist, is giving patients a plan A, a plan B, a plan C, because for many of the patients we see, they may obtain some pain relief with that plan A, but then they don't obtain that complete pain freedom, and that lingering pain can continue for the full day, a couple of days, 3 days, in folks we see with status migrainosus. So especially if a patient has an important life event coming up or an important, anything going on at all, I start off with plan A, which is usually triptan, with an NSAID and an antiemetic, and then their plan B would be to giving them the flexibility to repeat that. And then plan C can be, for example, a GPAN, and this is different for every single patient. But I really, really love giving them multiple modalities so they have flexibility.
Yeah, and my answer to this is going to be sumatriptan and ondansetron. Most insurances cover sumatriptan well. It's also the oldest triptan, so that's usually what I start with. And I completely agree with the importance of monitoring treatment and making sure that we have a backup plan. It's also helpful to document your thoughts in the notes so that when the patient calls, you've done your thinking once and you don't have to do it again. So this is results from a consensus statement that drew evidence from a systematic review of acute treatments for migraine and broke the level of evidence down into level A and level B, level A, of course, being the best. And I think these are all the familiar treatments that we are used to thinking about, including all triptans and all formulations. There's newer classes of treatments, including dietans. Lasmiditan is the only one we have in that class. The GPANs, rimegepant and ubrogepant, and then zavegepant is available as a nasal spray. We also use prescription NSAIDs. If you can get it, dihydroergotamine nasal spray can be helpful. There are also some combination treatments that we see as effective but have higher risk of medication overuse headache, and so we want to be careful about those. So moving on a little bit to the newer treatments and talking about them in more detail, we're going to have some slides each on the GPANs and dietans. One of the things that's worth knowing about them is that rimegepant is a 75 milligram orally dissolving tablet that does not have a repeat dose recommended, while ubrogepant does allow a second dose per 24-hour period. In terms of when to consider these, most insurance companies require a patient to have tried at least 2 triptans before covering these newer medications. But if the patient has a contraindication to triptans, for example, cardiovascular disease or uncontrolled hypertension, insurance may cover them sooner. In patients who do not have insurance limitations, I don't have many of those in my clinic, but for people who do have insurance limitations, some of us have started prescribing these earlier on in our treatment pathway. So kind of talking in more specificity about gepants in particular, one of the nice things about them is that they are by and large better tolerated than triptans with a much lower side effect profile. In clinical trials, about 4% of people reported nausea, about 4% somnolence. With the zavegepant nasal spray, a fairly high number of people, it was in the, I think, high 30s percentage-wise, reported dysgeusia. There was also some nausea more associated with that one than with the other gepants. One of the nice things about gepants is that they are not believed to contribute to medication overuse headache, and in fact, rimegepant is FDA approved for preventive treatment of migraine when given every other day. So these are really good options for people who are needing to take acute treatment more frequently because it may not contribute, like I said, to medication overuse headache. In terms of contraindications, one of the things to be aware of is that we don't have a lot of good information for safety in pregnancy, so they are currently not recommended for use in pregnancy. We do have some information about rimegepant in lactation that looks like it's preferred if you have to use a gepant. In lactation, rimegepant is the preferred one. And moving on to lasmiditan. Lasmiditan is a 5-HT1F receptor antagonist. The triptans are 5-HT1B and D targeted therapies. And B and D are both anti-nociceptive and also vasoconstrictive, whereas the 5-HT1F receptor has the anti-nociception without the vasoconstriction. So these are good for people who respond to triptans but can't use them out of concern for the vasoconstrictive side effects. One of the important things to know about lasmiditan is that it does have a fairly high incidence of side effects, including dizziness, paresthesias, somnolence, fatigue, lethargy, and some nausea. And it does impair people's ability to drive, even if they think they can, which is kind of a frightening thing as we're prescribing a medication. So there is this very strong statement that patients cannot drive for 8 hours after taking this medication, even if they feel that they're okay. So in my practice, I typically use this for nighttime or end-of-day rescue, although there are patients who are particularly disabled, and if this is the thing that works, then they're going to be in bed anyway. They would rather not have pain and be in bed rather than the alternative. And this one should also be avoided during pregnancy. We're going to hear more about that in a later case. So Dr. Curavilla was talking about the importance of having a plan B and a plan C. And this is really what we're talking about when we think about rescue therapy as well. So any patient who has significant nausea or vomiting, we need to think about rescue therapy because these are people who may not absorb the medications through the GI tract because they're vomiting. Anyone with rapid onset headache or for whom medications don't work some of the time or who have ever been to the emergency room for migraine are all people who we should be thinking about a backup plan ahead of time to avoid that Friday at 4 p.m. phone call saying, hey, I'm not doing well, what do I do? Non-oral formulations are particularly helpful in this situation, especially if there's nausea or vomiting. And this can include injections like the sumatriptan subcutaneous injection. Nasal sprays can also be helpful here, and suppositories. So indomethacin, the NSAID indomethacin, and the phenothiazine antiemetics, promethazine and prochlorperazine come as suppositories, and those actually help both with nausea and for migraine pain as well. They're level B for acute treatment of migraine. We try to avoid butalbital combination medications and opiates. Certainly they should never be given for first-line therapy. They have a high risk of medication overuse, headache. There are withdrawal symptoms with high daily dosing. Occasionally, in a very rare situation, it may be appropriate to give a small amount for rescue therapy, but practices vary, and I think as new treatments come on board, we are doing that less and less. One other thing to be aware of is that steroids can be helpful, particularly for patients who have attacks lasting longer than 5 days, which is termed status migrainosus. In my clinic, we sometimes also use valproate for 5 days. Different centers have different regimens, but steroids are certainly a big part of that. In addition to the things that we just talked about, drilling down more into other non-oral options, the dihydroergotamine nasal spray can be really helpful for rescue if you can get it. Again, we mentioned the subcutaneous sumatriptan. There are also triptan nasal sprays. We're going to hear more about neuromodulation in the next case discussion. And then again, for a nasal spray, zavegepant is available. So when we are thinking about how to choose from all of these acute treatment options, choosing the right option for our patient is really important, and we want to consider the speed of onset of attack, because headaches that ramp up very quickly need something different than headaches that start slow and seem to last forever. Severity of attack has to come into consideration along with, again, the GI symptoms, things like nausea or vomiting. And we've talked a little bit about when to choose new treatments, basically failure of 2 older triptans, or other therapies, or those contraindications. But I'm really interested in hearing from both of you. How do you choose the right option for your patient?
It's really based on patient preference and patient lifestyle. For example, if I have a patient who is a pilot, and this has really happened in my practice, I may not go for a triptan, for example, just based on the potential side effect profile. I wouldn't use something on the sedating side. If I have somebody with a history of GI comorbidities, then I'm definitely going to go for one of the non-oral options, for example. What about you?
Yeah, I think at any point, it's not wrong to say that you should really always remember shared decision-making is probably the most important point. Shared decision-making should be one of the most important things that you remember to do with your patients in selecting therapy. That's what I meant to say. So, some folks might be sort of medication averse, and some folks are going to be, really worried about, well, how many days can I treat with an acute therapy in a month? And so I think getting a sense of what your patient's needs are really important, and then hearing from them about what's important to them, what side effects are, tolerable and what are intolerable.
Once we have given an initial acute regimen and the patient comes back, often we ask, how does that work for you? And they'll say, yeah, it works okay. I hear that a lot. It's good, it relieves the pain, makes things a little better. In today's day and age, with the treatment options that we have available, partial response is not what we're looking for. We are looking for complete pain freedom within 2 hours. We also want to ask our patients how quickly the treatment is working, whether it reduces their associated most bothersome symptoms. So if they're particularly bothered by photophobia or nausea, we want to know that the acute treatment is working for that, as well as for the pain. We also want to know about whether they're having side effects, because if it works really well but they're avoiding taking it because it makes them too fatigued, then that's not an effective treatment for that patient. We have to find an alternative. We also want to ask about cost, because again, I feel like we're talking about insurance incessantly, unfortunately, but many patients increasingly have cost-sharing arrangements with insurance that limits the amount of medication they can get or their access to it, and that matters. If a patient can't afford a medication, they're not going to take it, and that means it doesn't work. So asking about all of these elements at the follow-up visit after prescribing acute treatment is just as important as prescribing the acute treatment in the first place. One of the other things that happens is that a medication will work some of the time or not others, or it will work in the beginning and then it will stop working later. So here are some things that we can do to try and get the most out of acute treatment for our patients. The first thing is that they should be counseled to treat as early as possible. Now, of course, this is different in a patient who's having 30 headache days a month, but in patients with episodic migraine, They should carry the medication with them, and they should take it as soon as they know that they're going to have a moderate to severe headache. Many, many studies have shown that the clinical effectiveness of triptans in particular, but gepants as well, is better when patients take it when the headache is still mild rather than waiting until the pain is more severe. If you've prescribed sumatriptan 50 milligrams, bump it up to 100. Sometimes that's all I have to do to get it to work really well and reliably for a patient. So use the maximum dose. We can change formulation or route of administration, so patient responds to sumatriptan some of the time but not others. Maybe that's someone who needs an injectable sumatriptan prescription. If we feel like we've maximized what we can do with a treatment, we can change what we're giving within class, so from one treatment to another, or we can switch to a different class. We can also use combination therapies, so triptans and NSAIDs, or triptans and antiemetics, or sometimes we use all three, or a gepant with an NSAID or an antiemetic. And then we also want to think about preventive therapy. If someone is feeling pretty disabled by their attacks and the acute treatments are not taking that away, that is an indication for preventive treatment. So here are some pearls for prescribing and thinking about acute treatment. Every person with migraine needs reliable acute treatment. It is by definition a moderate to severe headache. I have never had a situation where a patient came in, told me they had moderate to severe headaches, and didn't want to do something to help themselves feel better. We particularly want to think about migraine-specific treatments like triptans, ditans, or gepants in patients with moderate to severe attacks. We've talked about non-oral treatments and when to use them, and we want to consider neuromodulation or gepants when we are concerned about the overuse of acute treatment in addition to starting prevention in these patients.
Okay, so I'm tasked with talking about non-drug treatments today. So we have I'll start off by saying actually before we jump into the case that when I've surveyed people in the past with a study and we looked at around 400 people and asked them if they used non-drug approaches. 90% said that they used non-drug approaches and 50% said that they didn't discuss it with their clinician. So that's a really big reason why we have to actively ask patients what they're taking as far as non-drug approaches go, because they're likely going to be on it, and why we have to know about all these non-drug approaches that are coming up. So here's our case. A 49-year-old woman with a history of migraine with aura since her 20s presents with 4 headache days a month. 2 of these days are severe. She experienced intolerable side effects on nortriptyline and topiramate. Sumatriptan works within 2 hours, but it makes her feel awful. She would like to avoid taking prescription medications if possible. So let me pose the question here to my colleagues. When do you think about them?
Yeah, so I'm usually led by the patient here. So if a patient comes in and has questions about non-drug therapies and has an interest in pursuing these things, I don't extinguish that excitement, and I definitely play that up and offer those treatments. If someone doesn't offer that initial excitement, I don't often start with those things, but it's definitely in our armamentarium. I usually sort of layer it on with conventional therapies.
Yeah, I ask every patient about non-pharmacologic interventions as part of my initial visit because so many patients have experience with them. And it's just helpful to know what they've tried, or maybe they haven't and they're interested. So that's a routine part of every discussion that I have initially. So I tend to use these in 2 situations. One is layering on, like Dr. Ray Hill said. The other time is if someone has lower frequency episodic migraine and is not interested in pharmacologic prevention at this time, but we still feel that they need to do something. And so that might be a place where I would start with a non-medication option.
Thank you. So it's really interesting. The National Institute of Health does a survey every year, surveying anywhere from 30,000 to 60,000 patients in the U.S., and every 5 years, they specifically ask questions about integrative medicine. And what's really interesting is non-drug approaches are most commonly used in the Midwest and the West, and least commonly used in the South. And the folks that end up using these approaches the most are women who are Caucasian and Asian and of a higher education level. So, I mean, those are just some interesting facts that I thought about. I mean, geography matters, the patient you're talking to matters. And so here are some of our evidence-based non-pharmacological approaches that have evidence. And so these are divided up into 4 different baskets. One is body-based approaches, like our physical therapy and acupuncture. Neuromodulation, which we'll talk about in a few slides. We have 5 FDA-cleared devices that are approved for the treatment of migraine. Mind-to-body approaches. In the US, from that National Institute of Health survey, the most common approach used by patients is typically yoga or mind-body approaches. And then we will also touch on nutraceuticals. And then many of us, I'm sure, do this in our clinics already, but we also want to counsel patients about their everyday life, about exercise, sleep, nutrition, and hydration. One thing I'll say about exercise is that patients ask me what type of exercise, and most of the evidence has been for high-intensity aerobic exercise. And interestingly, exercise the science has showed that it can block the inflammatory factors, the cytokines in the body, and it also can help with our stress hormones, specifically cortisol and growth hormone. So this is a really important piece that patients can do at home. And then sleeping and waking at regular times and making sure to get enough sleep. I'm just going to say an interesting point here because I know every state doesn't have this, but daylight savings. I'm based in Connecticut. I got the most phone calls than I got the whole year. That I would say the first 2 or 3 weeks after daylight savings. Have you?
Yep.
It is crazy, the connection between circadian rhythm, stress hormones, and our sleep hormones and migraine. So they're, really counseling patients about this, especially when the days are longer or the days are shorter, is really, really pertinent. And then, of course, nutrition and hydration, regular meals and making sure they're not skipping meals. That's a very big issue among my patient population. And so let's jump into nutraceuticals here. There are a number of nutraceuticals that are available for the treatment of migraine, specifically for the prevention of migraine. The most popular ones are typically magnesium and riboflavin in clinical practice. Oftentimes, patients will even come in on these already. They've already Googled, they've already been in a migraine forum, and they've started their dosages. Magnesium does tend to cause diarrhea for a number of people, so I typically start at 200 milligrams and increase each week by 200 at bedtime until they get to 600. And as far as the other supplements here go, Butterbur was a part of the headache guidelines many years ago, but was removed because of the potential hepatotoxicity with the treatment. There is one specific formulation that has been purified and is specifically developed in Germany that some of our colleagues still use. But overall, this is something that we really have to use with caution and monitor very closely with liver function, because hepatotoxicity has been the big issue. There's also options for feverfew, which we absolutely cannot use in pregnancy because of possible uterine contractions. Coenzyme Q10, melatonin, which was actually showed to be equivalent to amitriptyline in a very small study that was done in Brazil, and then vitamin D. We know our MS colleagues have been in this vitamin D space for a long time, and now I really make sure to draw a vitamin D level if I'm getting lab work for a patient, and really try to supplement that vitamin D, because I have seen as a supplement to mainstream pharmacological therapy, it's very helpful for patients. Most people are vitamin D deficient where I live in Connecticut. Most people are running in the 30s, the 20s, so really good to check that. The next section here is on mind, body, I should say, more mindfulness and different approaches that can be done with a psychologist or a pain psychologist. We have relaxation training, biofeedback, cognitive behavioral therapy. And these are really, really useful approaches when you want your patient to practice psychological or cognitive flexibility. We know we have patients in our clinic who are often catastrophizing their pain, right? And they're telling us that you can kind of tell if a patient is mentally flexible or if they're able to have that resilience that someone really does need if they have a pain condition, especially chronic migraine. So you might consider one of these approaches when you see that in your patients. Some specific patients where you may want to consider these approaches for are people who may have had a bad experience with mainstream medicine in the past, have contraindications, or you just want to add it onto the therapy. Many headache centers require that some of these approaches are added on with mainstream therapies. We can certainly use it for folks who may have medication overuse headache and high migraine-related disability, and we'll talk more about that. So cognitive behavioral therapy, many of my psychology colleagues really summarize this as restructuring the brain, restructuring the thinking, and identifying what a person can identify in their everyday life that can help them change that thinking. So they learn cognitive skills about negative self-talk. They develop thoughts about coping, and this is typically with a psychologist. And they do get some relaxation strategies, and they learn how to adapt to the disease, which is the most important thing. I found this so useful for my patients. And there's also CBTI for patients with insomnia, which is a common comorbidity for people with migraine. So I highly recommend this. So biofeedback, this is one of our headache colleagues at Stanford, Dr. Zhang. In Connecticut, we haven't had a ton of luck finding somebody who has the biofeedback equipment because it is so expensive. If it's something that's available, I've found that it's extremely helpful because patients can see and regulate their muscle tension because they're attached to EMG. They can monitor their temperature and other modalities like their heart rate by just doing relaxation, breathing exercises, and this is typically done with a psychologist as well. And relaxation training. I think many of our patients are actually already doing this, right? With the apps that are available, Calm, Headspace, all these various apps, they may be doing this already. But the different techniques that are available are guided imagery, progressive muscle relaxation, and diaphragmatic breathing. The figure 4 breathing is what I typically teach the patients in clinic and tell them about. One app that may be helpful in the practices, because sometimes it's hard to find psychologists who see patients in your area, is Juva, which was specifically developed for people with migraine. I think it's available on both phone platforms, but it's a good one. And we have neuromodulation. So in my practice, I do tend to talk to most patients about neuromodulation because patients love being in control of their disease and treating their disease, right? They want to have some control. They don't want to feel out of control. So many patients are supplementing their acute treatments and preventive treatments with devices. And all of the treatments listed here have randomized sham-controlled trials to back them up. Specifically, the ones with the most sample sizes in the trials are the supraorbital transcutaneous nerve stimulator and the remote electrical neuromodulation device. Just a comment about the supraorbital transcutaneous nerve stimulator, it is attached to the forehead right over the supraorbital nerves, and it's used for 1 hour as needed when one has an attack, and used for 20 minutes at bedtime nightly for the preventive management of migraine. The other one here that also has good sample sizes in the trial, the remote electrical neuromodulation, it's been FDA cleared for adolescents, people who are 12 or above, and it's also indicated for the acute treatment of migraine by wearing it. It's an armband that goes over the arm for about 45 minutes as needed, and then also approved for prevention by wearing it every other day. I'll just say one other thing here is that sometimes these devices can help patients cut down on the amount of as-needed medication they're taking. For example, I have a patient who only gets 4 L-triptan a month. And then so she likes to supplement sometimes the milder attacks with a neuromodulation approach, and then really reserve that L-triptan for a more severe attack. So the only one here that does not have both indications is the external combined occipital and trigeminal neurostimulator. So the treatment plan for this patient, I would love to get opinions from my colleagues about this. What would you do?
Yeah, so I think definitely switching from the sumatriptan to almotriptan if they were bothered by that triptan side effect makes sense. And as far as the other preventive therapies, I think this is a reasonable approach. But referral to pain psychology and biofeedback, you have to really consider like the time it takes to do these things too, and the cost. Of course, there are always co-pays. And so again, I'm sounding like a broken record, but shared decision making is important here. And kind of getting a sense of how necessary these other layered treatments are is important.
The other thing you have to consider when you're thinking about what treatment to recommend is what is available in your area, because we don't have biofeedback, where we are, but we do have a really fantastic CBTI person as part of the sleep center. So any patient who has insomnia and chronic migraine, I will refer to her. We also have a really fantastic craniosacral therapy person in our area. So anyone who's got neck pain or a musculoskeletal component to their headaches, I'll refer. So a lot of it just kind of depends on, what the patient's presentation, but also what's available in your area.
Yeah, that makes absolute sense. One question I got when I was giving this non-drug talk in the past is, why didn't you include chiropractic maneuvers? And my answer, I know that's a loaded question, right? It's just because a lot of the trials looking at chiropractic maneuvers don't have a sham arm or a sham arm that is comparable to the active arm. So that's the only reason that it's not included in one of our evidence-based approaches. That's me.
So now we're going to move on to talking about preventive treatment with another case. This is Devin, who is a 36-year-old man with a 16-year history of migraine, and over the last 2 years he's seen worsening in frequency, and he's now having 2 to 3 attacks per week, generally lasting 1 day, sometimes into 2. His triptan used to be consistently effective, but it isn't anymore, and now he is missing work about once a month. I don't know how many lawyers you know, but missing work once a month is a really big deal for someone in that situation, not that it isn't for everyone else. So now what? What else do you want to know about Devin?
Okay, am I annoying yet? I'm going to say I want some shared decision making. So I think this is one of the parts about being a headache doctor that I like the most. You really have to get to know your patients and what's important to them and what their concerns are if you're going to have success in finding a treatment strategy that works for them. So, I would ask things like, do you have a regular routine sleep schedule? If not, like maybe a tricyclic isn't the one for you, et cetera. And so I might, give them a couple of options and tell them all the, potential adverse effects, and then, get their buy-in about what seems more acceptable to them. So.
In my area, I work with a number of corporate lawyers, and let me tell you, it's scary. It's really scary. They talk about billable hours, and losing 1 day of work is a major issue for them. I would definitely hone in on some of the lifestyle factors that he may be having from day to day, because specific types of lawyers do tend to have longer hours and may not be prioritizing those lifestyle factors. And in this particular case, I would go over the fact that, we don't want the horse to go. In this case, the horse has kind of gone out of the barn because he's having 2 to 3 headaches per week. So that kind of translates to 12 a month, even though he's only missing work 1 day. The American Headache Society has previously put out a statement that we should be treating anybody who has 4 or more headache days a month or any number of headache days with disability. For example, I have a patient who's highly functional and has hemiplegic migraine. And of course, I've initiated prevention for him because it's such a high-stakes disease.
Dr. Kuravilla is giving my next slide for me here. It's a good thing. It's not a bad thing. It's a good thing. So yeah, these are the things that we think about when we're considering preventive treatment. That attack frequency is one of the major criteria that we use with an attack frequency of over 1 per week, but disability is another one of the things that we think about, and someone who has significant disability with lower attack frequency may be eligible for prevention. Anyone who has medication overuse headache should be considered for preventive treatment. Uncommon migraine types that are particularly hard to treat with acute medication or extremely limiting to the patient may benefit from preventive treatment. And patient preference, some people simply do not want to have attacks, and while we can't ever promise 100% attack freedom, some people may simply decide that prevention is right for them. So here are the things that, the criteria that our patient met. So we've talked about this a couple of times already, but disability is very important when we are thinking about when to start prevention. It is kind of a matrix of frequency and disability. Basically, patients are going to come in and tell you that they're not okay. And anyone for whom acute treatment has been optimized and they're still having episodes where they're feeling that they can't live their life to the fullest is someone who you should consider prevention in. I mentioned that medication overuse headache is an indication for prevention. And one of the strategies that used to be used in medication overuse headache was to simply withdraw the overused acute treatment and tell patients to come back when they had done that. How many of you have tried that and had success? One person. Good for you. It works occasionally. But a lot of people have a really difficult time coming off of their acute treatments. They're using them for a reason. And for that reason, this was a PCORI-funded trial, medication overuse treatment strategy trial, which randomized 720 participants to either just starting on preventive treatment and not really saying anything about the acute treatment at all, or starting preventive treatment and switching the overused treatment to an alternative acute treatment with a limit of 2 days per week. This was a non-inferiority trial, and what they found was that both of those strategies were about as effective. So they both reduced moderate to severe headache days at 9 to 12 weeks. And the secondary outcome was switching, and whether people, was a consumption of medication, of acute medications. And the group that switched from the overused acute treatment to a different treatment did reduce their consumption of medication by 52% versus 32% in the group that only started prevention. So it still may be helpful to recommend an alternative treatment. In this case, I would prefer a Gepant over a triptan in addition to prevention if I had the ability to do that. So the conclusion is that for patients with chronic migraine and medication overuse, the efficacy of starting or optimizing preventive medication is not dependent upon whether patients first reduce their acute medication. So we have moved beyond the days when we tell people to simply stop their overused medication and then come back and see us. Every one of those people should get a preventive treatment. At the time that we start preventive treatment, it's important to be upfront with patients about what the goals are, because it's not no headache. We all wish that we could tell our patients that that's what was going to happen. And certainly with newer treatments and combination treatments, sometimes people get pretty close sometimes. But we consider a reduction of 50% headache frequency to be a positive response to a treatment, and we're going to keep that one and keep going. We want to reduce acute medication requirements. We want to improve response to acute medications, reduce headache duration and intensity, as well as frequency, and together all of those things result in reduced headache-related disability. So moving on to what the options are, this is kind of a busy slide, and to be honest, we kind of went back and forth about whether we should alphabetize or whether we should break it down by category, and in the end, we decided to just leave as is because it's all going to change. The American Academy of Neurology is in the end stages of finalizing the new preventive treatment guidelines for migraine. And I feel like I've been saying this for the last year, but they should be coming out for comment soon. And I think that's going to kind of shuffle this a little bit. I do think that all of the CGRP monoclonal antibodies and onabotulinum toxin, topiramate, the beta blockers, and valproate are still going to remain at the top of that list. Some others may shuffle around a little bit. So you can take a picture of the of the slide, but be on the lookout that this is going to be updated. And I did just tuck into the corner there a summary of a recent paper from the American Headache Society. It was a position statement saying that the CGRP targeting therapies should be considered as a first-line approach for migraine prevention, along with previous first-line treatments, without a requirement for prior failure of other classes of migraine preventive treatment. So right now, most insurances are requiring that a patient try and have poor response to or not tolerate two of the older oral ones, and the American Headache Society thinks that we should not have to do that anymore, and I do personally agree. So we'll have to see how that changes going forward. So I'm not going to talk about this in great detail because I think a lot of you are familiar with these newer treatments already, but there are 4 monoclonal antibodies targeting CGRP or its receptor. Eptinezumab is given IV. The other 3 are given as subcutaneous injections that are done either once a month or once a quarter in the case of fremanezumab. They're all pretty well tolerated. Injection site reaction is an issue, particularly with fremanezumab and galcanezumab, whereas irenyumab is more likely to cause constipation, but has a lower risk of injection site reactions. So here are some common questions we get about the use of CGRP monoclonal antibodies. So some people think that because they are sort of gated by insurance behind a couple of other treatments, that they are similar to onabotulinum toxin. Onabotulinum toxin is only approved for chronic migraine, and sometimes people get that mixed up and think that the CGRPs are also only approved for chronic migraine, but that's not the case. They are approved for episodic migraine as well. I often have patients ask whether they can use them in combination with onabotulinum toxin. Anyone who was at yesterday's talk on sort of newer migraine therapies heard an entire lecture about this. There is increasing evidence for improved efficacy with the combination of the two. Do they work in people with refractory migraine? They do. They work in people with medication overuse headache as well. They work in refractory migraine with medication overuse. We have really good quality studies for all of those patient populations. They can start working pretty quickly. There are some sub-analyses of clinical trials showing that onset of benefit can be within the first week, or in the case of eptinezumab, within the first day. How long should I wait to determine effectiveness? It does increase over time for many patients, and so it varies a little bit, but I think the current opinion is somewhere in the 4 to 6 month range. And then how do real-world results compare to clinical trial results? Similar effectiveness. Real-world trials or studies may be finding higher rates of constipation and hypertensive events with irenyumab. So I wanted to just hear a little bit about your experience in using CGRP monoclonals in clinical practice.
Yeah, I mean, I think that they've been a fantastic addition to our toolbox. I use them extremely commonly in my practice. I will make a point about, how long is an adequate trial. So I think you mentioned 4 to 6 months. I think it sort of depends. So if I have somebody with lower frequency migraine, usually I get a good sense of whether or not it's going to help them within that 2 to 3 month range. But if I have somebody with more intractable chronic migraine, I definitely give them that 6 months. It's an opportunity cost to ask your patients to stay on a medication if you're not sure if it's helping, right? But there are some data to suggest that you can even get a continued improvement up to 12 months. So I think patience with that group of medications is warranted.
What about side effects?
I think that from my perspective, they've all except for Irenuimab in my practice, I've seen pretty favorable side effect profiles. With the injection site reaction that you mentioned earlier with galcanezumab and fremanezumab, those don't often come up within my practice, and patients have, pretty well tolerated that particular one. But with Irenuimab, I did end up seeing a number of people with alopecia. They were not happy with me, and then constipation and oral ulcers in particular. And I will say, another common question that I get is, if I switch between a mAb that targets the ligand versus targeting the receptor, will there be a different response there? And there was a retrospective cohort study by Ione and colleagues more recently that showed that there wasn't real efficacy if we were switching between a receptor mAb, like, for example, Irenuimab, and a one that specifically targets the ligand, like galcanezumab, for example.
So one of the other questions we often get is, we've been talking a lot about shared decision-making and the importance of personalized treatment, but what does that actually mean in practice? So what that means is when we're looking at the person in front of us, we're thinking about the features of the headache. We're thinking about what the patient's comorbidities are. We're looking at medication interactions. People with migraine, particularly chronic migraine, have an extremely heavy burden of comorbidity. And so polypharmacy is a real issue in many of our patients. It's honestly another reason that a lot of us like the CGRP monoclonal antibodies, because they don't have drug-drug interactions. And then patient preference, we're going to ask, what do you care about in terms of side effects? What matters most to you? And use that to inform our decision-making, along with the levels of evidence that I presented earlier, because we're certainly going to try to give patients something that's going to work well for them. Again, I mentioned the high burden of comorbidity. Comorbidities, just to kind of take a moment to talk about them, they complicate the diagnosis. Migraine and depression have a bidirectional relationship, so having a diagnosis of one makes the diagnosis of the other more likely. Comorbidities also inform and also limit treatments. Because we don't want to give our patient a preventive treatment that's going to make one of their other comorbidities worse. Many comorbidities are risk factors for progression from episodic migraine to chronic migraine, including obesity, asthma, poor sleep, all of the mental health conditions. And so we need to be thinking about the presence of those and trying to refer patients appropriately if we can. And of course, comorbidity contributes to disease burden. It increases the economic impact and reduces health-related quality of life for our patients with migraine. When we're talking about patient preference, again, we come back to this over and over again. One of the things we have to balance, and I would argue probably the real crux of it, is we're balancing side effects versus efficacy. This is going to determine what kind of treatment we choose. Are we going to choose something that is pretty benign side effect-wise, but may have a lower evidence for efficacy, or are we going to choose something like topiramate that we know works really well, but tends to have a pretty high side effect burden for patients? This question also influences the dose that we start at and how quickly we go up. So all of this is going to depend on the patient in front of us. So we just kind of bring things up, talk with them about it, offer options, and then come to a decision with them. So, some pearls on preventive treatment: disabling attacks, poor response to acute treatment, and frequent use of acute treatment are all good reasons to start prevention. The MOTS trial tells us that we should be starting prevention in all patients with medication overuse headache. We just reviewed the differences in dosing strategy, and if we mention shared decision-making one more time, they're going to throw us off the stage. So,
I might do it.
pregnancy.
Don't throw me off, okay? I'm probably going to say it again. Okay, so our next case, we have a 35-year-old woman with a history of episodic migraine without aura. She's now 14 weeks pregnant and experiencing an increase in migraine frequency in the past month. Prior to getting pregnant, she had 1 to 2 migraine days a month that were effectively treated with rizatriptan. In the past month, though, she's been having 3 to 4 migraine days per week. That's a big change. No change in the character of the headaches themselves, and she thankfully has a normal neurologic exam. But I bet all of you are scared, right? Oh, she's pregnant, what do we do, right? Should we just tell her to tough it out? Please no. I get so many calls from my residents saying, I staffed a patient in clinic and we basically didn't offer her anything, so what do you think we should do? So first of all, before we actually talk about what the safe and effective treatments that you are able to offer to pregnant patients are, I want you to all think about that in the meantime. I want to ask my colleagues, how do you start this discussion with your patients? Like, what do you tell them to expect? Because it's a really scary time, and I'm sure they're thinking, well, I'm pregnant, so I really just can't take anything, can I? What's going to happen?
Yeah, so one of the things that I want to always emphasize to patients is that there are many things that they can take, and that we are not going to abandon them, that I am here for them, that we are going to do this together, and it's going to be okay. One of the other things that I can share with patients is that most people, about 2/3 of women with migraine, do experience improvement in migraine activity after the first trimester. So it doesn't always happen, and people with migraine with aura may be less likely to improve than others. But a lot of the time they do get better, and it's just a matter of getting them through that kind of unpleasant first trimester, which honestly is often pretty bad anyway.
I think the biggest thing that I try to do is do a lot of preconception counseling. I think it's really helpful to, once you get to know your patient, to talk about and ask, what are your plans for pregnancy? If the patient is of childbearing age, and what does that look like now? In this era, people of childbearing age go all the way up to the 50s now, right? I had a patient who was 51 who actually gave birth. In the advent of in vitro fertilization and the number of hormones that are given during that particular treatment, we see worsening in those scenarios too. So I think it's really good to give that preconception counseling and not wait until they're actually pregnant to start the counseling process. And then what are my safe and effective treatments? I'll say for prevention, the first two things
don't rain on my parade. We're going to talk about that. Oh, and one other thing, great points, Dina, but 50% of pregnancies are unplanned, right? So even more important that Dr. Kuravila, talks about this stuff in advance of people becoming pregnant. I'm just kidding. I would love to hear all about all the treatments you want to give to your pregnant patients. Okay, so there are lots of options, which we'll talk about here. I'm not going to read off the slide, but we'll go through this stuff, okay? I think that there is some, inherent anxiety in treating pregnant patients because you're really considering the well-being of two people, right? And there's this dissonance that happens because you want to give somebody a therapy that's actually efficacious and well tolerated, but you have to consider the safety of your second patient, right? And so that dissonance really makes treating pregnant patients a challenge. So we do have, there was a systematic review that was done in 2021, largely based off of the AHRQ. And it basically sort of confirms what we already were doing in our practice, in that you can see that there are a variety of treatments that may be associated with fetal and child adverse events. The study showed that calcium channel blockers and antihistamines may not be associated with these events. And then it actually gave us some reassurance about the use of triptans in pregnant patients as well with our accumulating evidence, which I'll talk about more. Okay, so the American College of Obstetricians and Gynecologists came out with a clinical practice guideline in 2022 in August, just after the Continuum article I wrote came out in 2022. And it's sort of, we were saying slightly different things. And I think that more clarity is coming. But first of all, the acute treatments that ACOG talked about, I think are pretty much in line with what most headache specialists and neurologists are using. But it's a really dynamic and exciting part of headache medicine right now, and so I think more clarity will come. So here's what ACOG recommended in terms of acute therapy. So I agree, I think first line, I'm considering the use of acetaminophen. There was some talk about the concern for ADHD and other problems with the use of acetaminophen, but there was actually a study that came out like a week and a half ago in JAMA controlling for siblings, and when they looked at that, it didn't seem as much of a concern about these issues. So I personally feel like acetaminophen should be first-line therapy for our pregnant patients who need acute treatment of migraine. They do list caffeine and diphenhydramine there. I think of these things as sort of like adjunct therapies, and of course with caffeine you have to try to keep it to less than 200 milligrams per day. And metoclopramide, everyone forgets that metoclopramide actually has anti-nociceptive benefits in addition to its anti-emetic benefits. So that has been long used in pregnant patients, and so that's one of the first medications I prescribe to my pregnant patients who need acute treatment for migraine. So I'm glad that sort of ACOG and my experience as a headache doctor align pretty nicely. Here's my table from the Continuum article of that same fateful year, 2022. I do put lidocaine in there for subcutaneous and intranasal use, although they said that you should weigh risks and benefits in ACOG because there's limited data in pregnant patients. And then, triptans, I feel very comfortable with triptans as a second-line therapy. And again, ACOG said that you should really be measuring benefits and risks with the patients. So there was a recent systematic review and meta-analysis of 6 acute studies, and it really should give us some reassurance that triptans do not appear to increase the risk of poor pregnancy outcomes when compared to the general population. So there's no big sign of teratogenicity with, first trimester exposure, et cetera. This is based on triptan registries both in the US and Europe. Moving on to prevention. So this is what ACOG recommends for prevention of migraine. So this is what gives me a little bit of anxiety because there are some therapies that I have been recommending for my pregnant patients for migraine prevention that don't appear on this list of first-line therapies to consider. Though I think it's a good reminder that perhaps I should consider expanding my toolbox of different therapies to recommend to pregnant patients as first line based on the available evidence, and certainly these things are safe options. But again, I don't want to give patients a medication that isn't going to work, right? So you really have to consider the efficacy too. So is anything missing from this list, right? I'll show you my continuum table at the end here, but first of all, onabotulinum toxin A injections were missing from this list. It is sort of a point of controversy, although we, again, have accumulating evidence to guide us with our use of Onabot. We have about 500 cases of Onabot use during pregnancy reported to guide us in different ways. So it was mentioned the plenary. Dr. Kaiser talked about the 29 years of data from the Allergan database about basically talking about the signal of whether or not there's a teratogenicity signal from early Onabot exposure. And so it didn't really follow pregnancies into the second and third trimester, so we can't make any conclusions about pregnancy outcomes from that data set, really. Whereas there was a case series of about 55 patients where they were treated with Onabot through their pregnancy for chronic migraine. And so, they reported no big signals for concern, but again, it's only 55 patients. So, do you guys use Onabot in pregnant patients? In the interest of time, we'll say yes, no, sometimes.
No.
Okay.
I haven't, but I probably would.
Yep. I love those short but sweet clinical pearls. Raise your hand if you use Onabot in pregnant patients. Okay, yeah. More to come. So, although we have this limited data set, this is my favorite case report, and I know that's a really nerdy thing to say, but it was exactly what Dr. Birch said to me when she showed me this case report. So this is from The Lancet in 1996. And it talks about a 37-year-old woman who had systemic botulism from eating spoiled canned goods. So we're talking about thousands and thousands of times the dose that we give patients for chronic migraine prevention, okay? And I love drama. This is so dramatic. At the most intense point of the disease, when she was almost completely paralyzed, fetal movements were the only visible motion. Crazy, right? She required tracheostomy and respiratory support for 2 months before recovering. Throughout this period, repeated abdominal echoes showed normal fetal development. She was discharged 3 months after onset of symptoms with only slight muscular weakness. 1 month later, she had a normal spontaneous delivery, and follow-up of the mother and child proved completely uneventful. So I feel like that's fairly dramatic, but it is an N of 1. So you can't really change practice based on an N of 1, but you can't deny that it's compelling. Okay, well, what about the CGRP monoclonal antibodies? So I think it's important to know certain things about this class of medications when you're considering implications in treating pregnant patients. So IgG crosses the placenta through the neonatal FC receptor at about 20 to 22 weeks of pregnancy and allows for placental transport. CGRP regulates the uteroplacental blood flow and uterine relaxation, which are kind of important. It may regulate, I think that should say, gestational blood pressure, preventing eclampsia and hypertension. It's mostly based on animal models. Animal studies did not identify reproductive toxicity, but we have not been able to really say this with any confidence in humans, of course. And it's important to note that, again, 50% of pregnancies are unplanned. These things have long half-lives. So they're going to be in your system for 5 or 6 months. And because they haven't been studied in pregnancy, the current sort of party line is that you should stop these things 5 to 6 months prior to attempting pregnancy. Okay, because of that theoretical concern about preeclampsia and as well as other potential concerns. Okay, so I'm going to not read off this slide, but suffice it to say there's very limited information about the safety of CGRP mAbs in pregnant patients, and this is pretty much it. So it's not enough to sort of hang our hats on at this point, okay? All right, so as promised, here's my table from Continuum in 2022. Again, you see at the top there, propranolol. I still recommend propranolol as a good preventive therapy in my pregnant patients. It's not without risk, right? So you have to weigh that benefit and risk, that safety, that efficacy with your patients. Magnesium, it does depend on the type of magnesium, the formulation, potentially. Onabot, I think in 2022 I said moderate safety, but it is very effective, and I wonder if that's going to change with the coming recommendations. I'm not sure. Verapamil I put down here, with ACOG that came out a few months later, maybe I would move some calcium channel blockers up the list and include more. So this is all, it's exciting because it's in flux, but stay tuned. So for the treatment plan for this patient, I think what's really important is that when you have a pregnant patient who comes to see you for migraine, you have to think about potential secondary headache syndromes. Although at 14 weeks, like our patient, I think the likelihood of secondary headache syndromes is much lower. You really have to start thinking about that after 20 weeks. But nonetheless, a good neuroexam is imperative, and sometimes other investigations. I think it's important to highlight the importance of lifestyle modification for sure. Maybe consider some magnesium. It's controversial, but it's a viable option. And, maybe some peripheral nerve blocks intermittently through her pregnancy. Maybe she doesn't need them as much as her pregnancy progresses. That's the hope. And then the acute treatments, metoclopramide, acetaminophen. I actually feel very comfortable, if those things fail, to give back the triptan that was useful to the patient pre-pregnancy. And this might also be a situation where you could talk to them about a remote electrical neuromodulation device to help with acute treatment in this case. What would you guys say?
Well, actually, everything here is probably what I would do first. And so I completely agree with the recommendations. I might expand to different devices, given that there's no systemic absorption with those. The only other thing I'd add here, there is a randomized study looking at yoga for the prevention of migraine, and so a lot of my patients like pregnancy yoga. So I encourage them to consider yoga and maybe do some stretching with a physical therapist. That tends to be helpful.
So the first thing I would do for this patient is an MRI. Because this person went from having, I think was one to two to having 16 headache days a month. And I agree that the likelihood of secondary headache is low, but that really worries me, and I wouldn't feel
Because you do that for anybody.
Yeah, exactly. An MRI without contrast is safe in pregnancy. It's the gadolinium that's the problem, but without gadolinium, it's perfectly fine. So I really err on the side of working patients up because migraine also increases the risk of things like preeclampsia and venous sinus thrombosis and other things. I would do all of these same things, except that instead of magnesium, I would start a calcium channel blocker. Because I'm on board with the new guidelines.
I would consider a calcium channel blocker. Propranolol is one that I might consider too. But yeah, I feel like in my opinion, I think that the calcium channel blocker and propranolol may be a little bit more likely to be efficacious as opposed to magnesium, but it's all in flux, so stay tuned.
Okay, so it's my turn again. Let's go through our last case here. Sadia is a 48-year-old woman with chronic migraine. She's had reduced severity and frequency with Anabat A and topiramate. She still experiences near daily headache with 8 severe days a month, and she uses a triptan on several days, NSAID for moderate days, and the REN device for her milder days. She's missing 2 to 3 days each month when her rescue of IM ketorolac doesn't work for her work days. She asks about whether she is a candidate for the new medications. So this is this kind of shows the evolution of what refractory and resistant has meant over time. In the early 2000s, some of the publications have showed that patients should really fail 4 preventive classes after an adequate trial to be labeled with that refractory term. And then later on, we see, okay, maybe it's 3 preventive therapies that they should have failed or not tolerated to be refractory. But most recently, the European Headache Federation has divided it up to people who are resistant, who have resistant migraine, and those who have refractory migraine. And the big thing I think about with these 2 categories is the folks who have resistant migraine have probably failed 3 preventives in the past, but may be very responsive to migraine-specific preventive therapies. These are the patients who we can tell them you're likely going to get better after we initiate some type of migraine-specific treatment that also may be layered with other treatments. And refractory migraine, by their definition, is basically failing everything, all preventive therapies. These are our patients who we cannot pin down the exact mechanism that's making them intractable, and they've tried so many different preventive treatments that it's getting very difficult to manage their disease. And many of our chronic patients fit into that category of refractory, whereas many of our patients who have high-frequency episodic migraine fit into the resistant migraine category. And that's not for everybody, but that does generally tend to be true. And so this is a narrative review that I did with a number of my colleagues that basically is a nice summary of everything that's available to us when we're really trying to give patients that pain freedom and start the appropriate preventive and acute therapies. And I'll just highlight one thing here that we haven't talked about yet, and that is layering preventive therapies. Many clinicians that I talk to in patients, they say that their clinician started a therapy, it didn't work, so then they stopped it and started something else. And they've gone through that process sometimes for many years. But really, starting low, increasing slowly, getting to your optimal dose may be very beneficial for patients, but they may not be pain-free. So then we tend to layer in that second treatment. And for those patients who are refractory, I mean, we probably have patients who are on 4 or 5 preventive treatments, right? That's very common sometimes in a headache clinic. So that's just the one point I want to bring up here, is to layer different modalities. And so what about combination therapy with specific migraine approaches? This is really interesting. Over the last couple of years, we found through basic science studies that specifically if we were to inject the dura with Anabot-A, we're able to specifically impact the C fibers, which are responsible for a delayed pain response. And we found that with our CGRP antagonists, like atogepant, we're able to directly impact and attenuate the A delta fibers, which are responsible for our fast pain response. So one of the ongoing thoughts and hypotheses is that the simultaneous use of Anabot-A and atogepant can block cortical spreading depression-induced activation and sensitization of those high threshold and wide dynamic range neurons in our migraine generator. And so what does that mean from a clinical standpoint? Oftentimes, for the patients who do have chronic migraine, I have many of them on both a CGRP preventive and also Botox in my practice. And I found that typically with one modality, they're able to get down 50% with their migraine frequency. And then when we add that second modality in, they're able to come down to single digits over a month. So this has been really helpful in my practice. And so more evidence here, does adding a CGRP monoclonal antibody to Anabot actually help based on the evidence? We found that Cohen and colleagues, and there's a number of authors here, but we see that patients may start off at 15 to 25 days of migraine a month, and then they're able to drop to 6 to 11 days a month when we put that Anabot and the CGRP monoclonal antibody together. And we all have those patients who say Anabot wears off between 8 and 12 weeks. In those cases, I do specifically consider a CGRP monoclonal antibody because it really helps with that wearing off phenomenon. And so what's the, and we talked a little bit about this, about Anabot-A prevents activation of those C fibers, which are our delayed pain response. They're responsible for our delayed pain response. And specifically, when we talked about CGRP monoclonal antibodies, fremonezumab was the one that specifically looked at the activation of those A delta fibers, or the that fast pain response. So it's been looked at with atogepant and with fremonezumab if we were to consider those to add them to Anabot for our patients. So would using a CGRP monoclonal antibody and a GPANT work? And do we do that in practice? In my practice, I do, because it's so interesting. There is this term that's been floated around since these medications came out of CGRP super responders, right? And so, in a number of patients, depending on the patient, I do tend to use both. But here in the evidence, we see that rimegepant, our Gpant, oral Gpant, plus a CGRP monoclonal antibody was possibly effective and well tolerated, but this was a small case series of around 13 patients. And we've seen that ubrogepant may be safe and tolerated with the CGRP monoclonal antibody. And more to come on when combining an oral CGRP antagonist with an acute approach. But generally, these are well tolerated in practice. So what about when we look at CGRP monoclonal antibodies and Gpants, we didn't see that there was a difference in a good responder rate or adverse event rate to a non-CGRP monoclonal antibody user. And prior treatment with a CGRP medication, like our super responders, may predict a response to that Gpant. So we really want to try to identify where CGRP blockade is the helpful mechanism with our patients. So what about combining Gpants, our oral Gpants with acute and preventive therapy? I'll just make one point here. It's basically that adding our preventive atogepant to, for example, our ubrogepant may change the side effect profile and make the side effects more likely with that ubrogepant. So things that may pop up and be more common are constipation, nausea, fatigue, back pain, abdominal pain, and neck pain when you're combining the two. But I do this in my practice. I have patients who are on atogepant for prevention and ubrogepant for acute treatment. Okay, so Sadia has questions. Which medication is stronger? Can I take the triptan and Gpant together? All right, so here's a comparison table that looks at the therapeutic gain with our acute treatment modalities. On the bottom here are our medications, and we also have the percentages of those pain freedom rates with acute treatment. And this is looking at the percentages of pain freedom between the active arm and the placebo arm for our therapeutic gain. And we can see here that rizatriptan is kind of at the top of our list with just over 30% of therapeutic gain. And then we see that rimegepant and ubrogepant are kind of dancing around between 5 and 10% for that therapeutic gain. And then combining in our mouse model, in our basic science models, we found that combining a triptan and a Gpant was not more effective than using one alone. In this particular mouse model, they tried to activate allodynia by using glyceryl nitrate, and they found that using each one individually was exactly the same as using both together. And here's some information from the Cameo study that basically shows folks who have discontinued their acute treatment medications based on different things. And that's what we see here, based on that lack of efficacy, safety, tolerability, financial concerns. And we're looking at that related to our migraine disability or our MIDAS assessment. And we see that when we think about patients who are the most disabled and the reasons why they're stopping their acute treatment, we really see comparability in the safety and tolerability column. So around 30% of people are stopping their acute treatment medication irrespective of their disability. And we also see similar rates within in the financial concern column, whereas people who are less disabled are less likely to stop those acute treatment medications compared to the people who have disability. And here are some risk factors for migraine disease progression. You know, we have non-modifiable risk factors that put patients at risk from going from that infrequent migraine to more frequent chronic migraine. And this is a table from Dr. Lipton's article talking about these different disease progressions. And so this actually gives us the risk factors in one column and tells us the protective action in another column. And I think we've talked about a lot of the protective options during the talks today for the most part. But it's basically optimizing prevention, optimizing acute treatment, and tons of education. And these are other typically non-modifiable risk factors for migraine disease progression, and really important factors to ask the patients about. when we're talking about comorbid pain conditions, head or neck injury, do they have anxiety and depression and some of these other conditions that we need to address at the same time that we're making our pharmacological and non-pharmacological recommendations? I mean, a multidisciplinary approach to migraine management is key. I mean, I'm usually working with 3 or 4 other specialists for these patients who have chronic migraine especially. 1 step forward, 2 steps back. We won with our prior authorization and were able to get fremanezumab approved. At the 3-month follow-up, Sadia reports a reduction. She's having 15 headache days a month now. She's no longer asking for more triptans from her pharmacy. She did have an EGD that showed some gastritis, so she's not allowed to use NSAIDs anymore. But I'm curious, do you guys agree with this, or what would you do differently?
Yeah, I think I would agree with this approach, and thankfully, because you've seen that reduction in headache frequency, the headache days per month, the patient isn't feeling the need to reach for their acute treatments as often, which is a win for sure. But I think, especially with these folks who have intractable chronic migraine, it really, don't kick me off the stage, I'm going to say it one more time, okay? Shared decision-making is important because I think there are some folks in my practice who still have that daily persistent headache, albeit mild. And I always talk to people about what option would be next, what I can offer for them. And there are some people who are like, you know what, I'm okay. I have a reliable acute therapy. Although I have daily headache, the intensity is mild. It doesn't get in my way. And I'm not bothered enough by it to warrant adding another preventive therapy. And then there are some patients in my practice who are like, I still have daily headache. Like, what else you got, doc? And those are the folks that I would layer on other preventive therapies. So it's really, really important, especially in patients with intractable chronic migraine, to engage them about what they want and just kind of be there to support them in the review of their options.
Yeah, I completely agree. It depends entirely on what the patient wants. And if we are going to start another preventive therapy, we go right back to the beginning and use the same decision-making process with taking account side effects and polypharmacy. And I will say that when layering, I have found that sometimes lower doses of preventive therapies can be helpful. Sometimes we don't necessarily need to use the highest dose of everything if we're using combinations of treatments.
Absolutely. All right, that's the end of the cases. Thank you.
Well, I had fun. I hope you guys had fun and hope you learned something. I want to have time for questions. We have a couple of questions online, but does anybody here have any questions for us about any of the cases we talked about? Don't be shy. Well, we have a question over here. While you're waiting for the microphone, hang on one second. We want people to hear you online. Somebody online said, can we expect anytime soon being able to start with injectables, G-pants, Ditans right off the bat without hoops? Well, as we briefly mentioned, the American Headache Society put out a consensus statement a couple of months ago, I think, right?
Mm-hmm. Last month.
Sorry?
Yeah, last month.
Oh, last month. It's been a long week. Last month, basically saying that a lot of these new therapies should be considered a first-line therapy in addition to our existing first-line therapies, which is huge. So hopefully that will help us in terms of getting these migraine-specific therapies available to our patients earlier. So thanks for that question online. What's your question?
So I want to talk a little bit more about access to some of the like behavior modification type therapies. Just for point of reference, I am here from Anchorage, Alaska, which is the land of no access. So thoughts for things to recommend for patients when I have zero access to anyone who does any of the things that you mentioned?
Yeah, great question. I mean, right off the top of my head, I would say leaning on apps. There are a lot of apps out there that can be helpful, but Dina, I'm going to give this one to you.
It's really interesting. For some of those approaches, there are virtual options, actually. There are virtual clinical trials that patients can get enrolled in. For example, Dr. Rebecca Wells is starting a clinical trial specifically for mindfulness-based stress reduction at Wake Forest. And she's able to take people from across the country because it's all done, everything is done virtually, all the teaching and everything. So there's a number of online resources and courses that, just for example, the American Migraine Foundation, National Headache Foundation, and those different websites are really able to provide so that patients don't have to leave their home for the approaches.
Great question. Anybody else? Right over here. Thanks for staying, everybody. I know most of you probably have to get to the airport soon, but.
Thank you for the great talks. I just had a pretty basic question. This is in relation to, I guess, who you'd start, or when you're thinking of starting preventative therapy for a chronic migraine patient. So, a lot of you explained how you wouldn't see many tension headaches in a specialized sort of headache center, but a lot of patients, if they might have 2 days of migraine type headaches that fulfill the criteria for migraine with your nausea and photophobia and everything, but then have 6-7 days of other type headaches. Often the triggers are the same, like lack of sleep or whatever it might be, stress or whatever, dehydration, whatever it might be, but they're characteristically quite different and distinct. They could be bilateral, not pulsating, all that. But technically they're still headache days. Would you still consider them? Would you add them together in your approach in saying that they overall have 15 days of headache, if it works out to be that, or how would you approach that?
Yeah, so if you have more than 15 days of tension type or migrainous headache a month for more than 3 months consecutively, then that's part of the diagnostic criteria for chronic migraine. But you raise an interesting point. Like, I think there are some headache specialists out there who say, is tension type headache, is sort of the milder headache days in someone with chronic migraine any different than tension type headache, which I think is an interesting question because we're dealing with the same headache machinery in the brain. But you're supposed to really code what patients meet criteria for. So some people would code, chronic tension type headache and episodic migraine if they don't have those 8 migrainous headache days per month. But I saw Dr. Birch grabbing for the mic as soon as you asked this question, so I want her advice too.
Yeah, so the criteria for chronic migraine require 15 headache days a month or more, 8 of which are either migrainous or the patient believes that it would have been a migraine if they didn't treat it. And most people who have headaches 15 days a month or more, and some of them have migrainous phenotype, are going to meet those criteria. In the US, we tend to believe that if the patient's most severe headache phenotype is migraine, that the underlying pathophysiology for all of the entire spectrum of headache that they have is migraine. In Europe, they tend to be a lot more interested in the concept of tension type headache and code those separately. So it's just a philosophical difference. But your question was really, when do you start prevention? And I think the answer is not to get hung up on the exact diagnosis and really to look at the number of headaches that they have per month, because somebody who has chronic tension type headache, we never talk about tension type headache in a talk like this because we just don't see them very often. But I'll tell you, if you've got someone with genuine chronic tension type headache, they're among the hardest patients to treat. But anyone who's got headache of any kind, 15 days a month or more, needs a preventive. I don't care what kind of headache it is.
Thank you.
Ask you about you were mentioning the risk factors that may worsening migraine. So you talked about anxiety, depression. Is that untreated anxiety, depression, or even when they're treated?
That's when they're treated as well. Many of the patients in our clinic, in my clinic, have been seeing a psychiatrist for many years, and oftentimes have cycled through several SSRIs and some of the newer generation antidepressants. Certainly uncontrolled anxiety and depression is one of the biggest risk factors for migraine chronification. But I certainly see folks in my clinic where they're already on treatment and controlled from that aspect, and they're still having frequent headaches.
So if I can add to that, I think I've heard many times in my career people say things like, oh, they have a lot of headaches, they're just stressed, they're just depressed, they're just anxious. That just drives me nuts to hear. So I think it's sort of an expected response when you're doing everything in your power to reduce your suffering and you're still getting hit with headache and you're still disabled intermittently by headache and you don't know when the next hit is coming, right? So if you do that to a mouse, they develop learned helplessness, right? And so it's no surprise that there's an association with depression and having migraine. And similarly, if you don't know when your next attack is coming and you have a big exam or you're getting married or you have to present at a conference, like, of course that's going to make you anxious. So I think it's really important to address these things and provide treatment options because that's the right thing to do. But I would also emphasize the importance of simultaneously addressing their migraine with migraine-specific therapies.
And I also want to point out that these relationships that we're describing in a talk like this are epidemiologic relationships. So basically what they're doing is they're asking people in surveys, or they're looking at routinely collected data and they're looking at ICD codes and they're saying, do you have one of these diagnoses and do you have migraine? And they're looking at the likelihood of having one of the other diagnoses in the presence of the first one. There is actually we have very bad evidence that treating any of these things actually prevents progression to chronic migraine or increases the likelihood of someone reverting from chronic to episodic migraine. We believe that that's the case, but we don't actually know that from a data standpoint. So the question of treatment is, I think, epidemiology, doesn't capture that kind of thing.
Great question. Anybody else? Thanks for running all over the room for us.
So that last patient you talked about, Sadia, and she has 15 days, headache days now on the Agevy. What's your next step? If she wanted to cut those down more, would you add like a Magox, or what would your options be?
I can tell you, within my practice, the first drug was fremanezumab that brought her to the 15 days. At this point, I'd probably add on Anabot A.
I'm just pulling up the case. Yes, I would also do the same.
Yeah, agreed.
Consensus.
I was surprised that magnesium was on the list of ones not to give on one of the list. So I was wondering, why would that be?
Oh, that's
it's used for.
That's a question
clamps.
with a good story behind it. So, in what was it, 2015? I think they did away with the FDA 14. They did away with the FDA safety categories, and so a lot of the oral magnesium formulations were A and B. But magnesium sulfate was demoted to D right before they did away with those safety categories because of a concern for congenital skeletal malformations because of its interaction with calcium metabolism. And so I have a friend who contacted the FDA and they were like, it's Dr. Birch, by the way, and wisely asked, well, so if magnesium sulfate was demoted, should we be concerned about these oral formulations? And they basically said,
They said they can't comment because it's the FDA, and they said the letter categories are no longer useful. Yeah, and it's the IV formulation that if you used longer than 5 days, that was downgraded from category A to category D.
but they also use mag sulfate by the truckload to treat preeclampsia.
Yeah,
of course.
and the FDA never commented on this, whether the safety category of other or oral formulations of magnesium were affected, and then they discontinued the categories. And the fights that go on the Facebook groups about this are amazing, which is actually why I contacted the FDA. It was because I was having an argument with somebody online. That tells you everything you need to know about me.
But I will say, I feel like The clinical effect, in my opinion, it's sort of modest, and I feel like there are more efficacious options out there. So because of this controversy, I'm not really using magnesium as like a first-line oral preventive therapy personally, but again, like all these things are in flux, lots of controversy.
Just a quick comment. The evidence does differ a bit between migraine with aura and migraine without aura. Magnesium does have pretty strong evidence for migraine with aura and all of the aura variations, but less evidence for migraine without aura. So if I see somebody with aura, that's usually the first thing that I'm starting with in many cases.
But I will point out that most of that evidence is for IV magnesium. That's true. In aura, not oral. So this is where, one of the things that we don't talk about, again, in a talk like this, is that we, in the world of migraine, we know everything there is to know about the CGRP monoclonal antibodies. We have giant gaps in our research in some areas, and things like magnesium is one of them. Calcium channel blockers is another one. There's very little evidence, and it leaves us in this very awkward position of, okay, well, do they not work, or do we just not have evidence showing that they do? So the issue with oral magnesium is that the epidemiologic studies that were done looking at the safety in pregnancy were done before this concern came out. So they didn't look at bone at skeletal for development in offspring as an outcome. So we don't have any evidence, again, one way or the other, about whether magnesium is safe. The chances, oral magnesium is very poorly bioabsorbed through the GI tract, and I think the chances that it reaches concentrations high enough to outcompete calcium in the fetal skeleton are very small. I took it during my pregnancies, but do I recommend it to patients first line? I don't.
So I told you that was a loaded question. Good job. In the interest of time, we have a minute left. I'm sorry if anybody had any burning questions, but as a medical educator, I'm a residency program director. For all of you online and in the room, I just want to emphasize that we do have these treatment gaps, and it is a really exciting time to become a headache specialist. And we need more headache specialists. There are only so many of us and so many people with migraine and headache disorders. But it's also an incredibly fulfilling career. So check out the American Headache Society, the AAN guidelines hopefully coming out soon. Lots to come. So thanks so much for staying, everybody. Thanks.